Hello, I'm Stuart Wright. I am an emergency physician and Associate Chief Medical Officer at UC Health.
Hello, I'm Dustin Calhoun. I'm an emergency physician and the medical director for emergency management at UC Health. So it is true in that pretty much no test is perfectly accurate. We don't have any medical test out there that catches 100% of anything. The test that we're using is very accurate. There are a number of things that contribute to whether a test really is or isn't accurate. Some of that is obtaining the sample. So when we do these, if we were obtaining a sample, we do it with basically like a long Q-tip. It goes into the nose and to the nasopharynx, the back of the nose area there, and has to collect a certain amount of cells and fluid that's back there. If a sample wasn't obtained sufficiently, it can definitely lead to a sample that doesn't give you the best results, and that can lower how sensitive the test is, how well it is at picking up. The other things that contribute to how well the test performs is how much virus the person that you're testing has, how much they're shedding. And someone who has just acquired the disease, where the virus is just starting to replicate, is going to have a smaller amount, and that test is going to be less sensitive. And the longer they've had it, up to an extent, it obviously starts to taper off eventually, the more likely the test is to be sensitive and to catch their disease. We don't know exactly at what point the test is most sensitive. We don't know the exact numbers. Those tests that we use, that we have those really hard numbers for, tend to be ones that we've been using for years and have a lot of data behind. We feel that in a patient who has symptoms, so someone who has had the disease long enough to replicate the virus enough to where they're manifesting those symptoms like coughing or shortness of breath, those kind of things, most of the tests that we're looking at and most of the data says that it's about 90% sensitive, meaning that about 90 out of 100 cases it's going to pick up. Now, the numbers that you hear sometimes in the media, the 20 to 30 number, probably is significantly confounded by the setting of either a poorly attempted or a poorly obtained sample, or some patients that were very early in their symptoms or had no symptoms at all, which is why our process so far, for the most part, with a few limited exceptions, doesn't test asymptomatic patients. There is not. Now, Stu, unless you know any more than I do about that, has anybody really started? I know they're working on it, but I don't know much as far as how far it's gone. I've been told that we really shouldn't expect something during this first surge of patients.
My understanding is that we're still probably 1 year to 18 months out from such an invention. However, I think in the last 5 to 10 years, particularly the Gates Foundation has been involved in speeding up our processes to develop vaccines more quickly. But more quickly, still in this day and age, means a year to 18 months.
That's still not 100% certain. The best theory that's out there, we know that it started in China, in the area around the city of Wuhan, in the Hubei province. It is thought to have been related to what some people refer to as live or wet markets, where you have non-domesticated animals in close proximity to large numbers of people. We do know from the the genetic material of the virus that it probably originated in bats initially, as is the case with some of the other coronaviruses that are out there. It's thought that there was an intermediary that was a pangolin, which is a little scaly armadillo type thing. That's what's thought to have occurred. So I heard a lot about this initially. There were people saying don't do it, and then it went back and forth. I think where everyone is standing right now, including the CDC and the World Health Organization, is that there isn't enough evidence to truly say stop taking ibuprofen, right? Because those medicines like ibuprofen, and it's just not that one, there's ACE inhibitors like lisinopril or something like that, that are also in those categories of drugs that people have thought might cause a problem. And what they're saying now is that there are reasons that people take those medicines. And if it's important that you be taking those medicines, there isn't enough evidence to say that you should stop them. We probably should avoid them when we don't need to start them in someone new. But if you're on lisinopril, your harm from not being on your blood pressure control is probably greater than the likelihood of harm from being on that if you get the disease.
And I think to carry on with that answer, we have other medications that you can use to treat those symptoms and signs of COVID. So for instance, if you have a fever and body aches, you can take Tylenol. So it would not be the time to start taking ibuprofen for this new illness. If you're on it long term, you shouldn't stop it. But if you're developing a new disease, you should try something else.
Yes and no. So we have to sort of define what we mean by going through the air. So certainly the respiratory secretions are the primary way it's spread in little droplets. For physicians and scientists, when we talk about spread through the air, there's a couple different categories of that, and it kind of depends on how small the little droplet is. Rarely, if ever, I don't think ever, you have just sort of the virus floating around by itself in the air. but different viruses do well in different sized droplets. In the case of COVID-19 and the SARS-CoV-2 virus, it is sort of the medium-sized to large-sized droplets, which can travel in the air. So when you cough, typically the little droplets that come out of your nose and mouth from coughing or sneezing go about 3 to 6 feet before they sort of drop off to the ground. So that is through the air, but they're not just floating around in the air. The only time that we really worry too much about that is when we do things that we call aerosol generating procedures. So if you're doing something like a nebulizer treatment for someone, or you have someone on CPAP or BiPAP or something like that, and some of the surgical procedures, those can put the virus into smaller little droplets and can put them up into the airstream a little bit better, and those can then be in the air a little longer.
And I think what Dustin's talking about with the 3 to 6 feet is where we get our 6 foot social distancing rule.
Right.
It comes directly out of that scientific literature.